All right, good afternoon. Let's go ahead and get started. So today's lab is going to involve just looking at some structures without a whole lot of dissection. You're going to examine some of the structures of the external part of the nose, focusing mainly just on the different cartilages that make up the nose. Then you're going to look briefly at the external ear, the flap on the outside of your head. We call that the pinna, and it has a number of different parts. There's a helix, an antihelix, tragus, antitragus, as well as the external acoustic meatus. You're going to look briefly at some of the structures in the anterior part of the eye, but not really do any real dissection of the anterior part of the eye. And then the only real dissection you're going to do in lab today is a dissection of the orbit from above, from inside the skull. So obviously we've removed the calvarium, we've removed the whole top of the skull. What you're going to do is you're going to go down through the frontal bone that forms the roof of the orbit from the interior of the skull in the anterior cranial fossa. You'll break through the frontal bone, which is really quite thin in the roof of the orbit, and remove the little fragments of the broken orbit, the broken orbital roof. Just pull out the fragments like little bits of eggshell, and then you'll have access to the structures of the orbit from up above. So that'll be your primary dissection today. When you get into the orbit from above, you'll be looking at the various muscles, what are called extraocular muscles, the muscles that surround the eye that are responsible for the movements of the eye. And you'll be looking for some of the nerves within the orbit as well. While you're working on those things, I'm going to be doing a demonstration dissection on one of the cadavers, where I'm going to try to expose some of the internal structures of the ear. So you'll be looking externally at the pinna, looking at the different folds and ridges and things on the external part of the ear. But I'm actually going to be dissecting into the temporal bone to see if I can reveal any of the internal structures, which we'll talk about shortly in today's lecture. So make sure you stick around long enough. Today should be another relatively quick lab, I think, because that superior orbital approach is fairly quick. Just looking at the ear, looking at the nose, that's all really quick. But just make sure you stick around long enough for me to do the demo. I can't make any promises about the demo. It's hit or miss. Sometimes we see some really cool stuff. Other times we don't see much of anything. I am trying something brand new this time that I have never done before. I bought a Dremel tool. I'm going to use that to grind away the bone. Normally I get in there with a big hammer and chisel, which I think is why the dissections are usually pretty variable, because it just depends on how I hit it and how hard I hit it with the chisel. So I'm hoping with the Dremel, I can do a more careful, more meticulous dissection and actually show you things like the cochlea, which is the spiral organ that's responsible for sense of hearing. Maybe if we're lucky, see the semicircular canals that are responsible for sense of balance. That's a little easier. And maybe actually get into the middle ear cavity where the three ear ossicles are, the incus, the malleus, and the stapes. I do have a tiny little box that I'm going to pull out at the beginning of lab today that contains some of those ear ossicles so that you can look at them. They will be on the exam. They're kind of like looking at isolated carpal bones in the wrist, only they're about 1/100th of the size. You'd be shocked at how incredibly tiny the bones of the middle ear cavity are. As of right now, I think I only have the incus and the malleus. I have a bunch of each, a bunch of incuses and a bunch of malleuses. I don't know what the plural with that would be in Latin. That's the hammer and anvil bones. The third bone, the stapes, is the smallest of all of them. I had one as of last year, and then during last year's class, somebody dropped it. And once it's dropped, it's gone. Because it is about 1 millimeter, maybe 2 millimeters in size at the most. It's so tiny it vanished. So if we're really lucky during today's demo dissection, I'll find another one, but it took me 20 years to find the first one, so I'm not hopeful. We shall see. All right, so lecture stuff. So you're going to want to briefly look at the nose. Of course, they're going to be all really dried out by this point. So you're going to have to just do your best to see if you can identify any of these cartilages. There are 3 different cartilages that actually make up the external part of the nose. 2 of them are paired cartilages, and then there's a septal cartilage in the middle that's not paired. So I guess really it's 5. There's 1 septal cartilage, 2 alar cartilages, and 2 lateral cartilages. So the septal cartilage is, as you might guess, that runs right in the midline, sits right in the mid-sagittal plane. You can see just a little thin sliver of the septal cartilage here, anteriorly running down the bridge of the nose. I think it's not labeled, but it would be sitting right in the midline here in this inferior view of the nose. You've seen the nasal septum in the bisected head. Part of that, remember, is made out of bone. So the vomer, the ethmoid, the palatine, they all contribute to the nasal septum, the bony part of it, but then most of the nasal septum is actually made out of cartilage, this septal cartilage. So that continues all the way out to the very bridge of the nose, as you can see here. Then on either side of the septal cartilage are a pair of lateral cartilages that form the sides of the nose. They're almost extensions of the nasal bone. So you have a bony part of the bridge of the nose, and then that continues as these lateral cartilages. And then the tip of the nose is formed from a pair of alar cartilages. The word alar pops up a lot in anatomy. It means wings. We'll see them in the pelvis. The sacrum has ala. You can see from an inferior view here how the alar cartilages have this kind of sort of U shape or kind of horseshoe shape when you view them from below. Interestingly, the alar cartilages have this kind of U shape. I think a lot of people assume that I should know this, but I can't remember what we call the little flaps on either side of the nostrils. I think a lot of people assume that the cartilages form those little flaps on the sides, but it's actually not the case. If you look closely at this little picture here from an inferior view, you see that most of that lateral bump that sits just lateral to your nostril is actually just made up of a pad of fat. The cartilages are only out at the very tip of the nose. So that shouldn't take you too long to look at those. You're going to want to take a look at the external structures of the ear, what's known as the pinna. I don't think that word is on here, but it's just P-I-N-N-A, just refers to the whole external part of the ear, on the side of your head. There is cartilage within the pinna of the ear, and of course it's then covered with skin, and it's the cartilage that gives it the very distinctive shapes and creates these different ridges and grooves and things on the surface of the ear. These are going to be pretty dried out also, but hopefully you can still identify all of these different parts even on the very dried out skin of the ears. So on the very outer edge of the pinna, there's this large ridge that runs all the way around the outer part of the ear, known as the helix. And then just kind of internal to that, closer to the external acoustic meatus, is another prominent ridge. So these form almost like concentric semicircles, with the helix being the larger one on the outside, and then the smaller one that lies kind of internal to that is called the antihelix. And that antihelix often has this kind of Y shape to it, where it kind of forks up near the top of the ear. The antihelix then surrounds this part of the ear that I'm circling with the cursor, known as the concha, which is almost like a funnel that leads into the internal acoustic meatus. And then the internal acoustic meatus is surrounded on the anterior and posterior sides by a couple of little bumps. The prominent bump that sits just anterior to the internal acoustic meatus is known as the tragus. And then there's a little bump just opposite that, kind of across the other side of the meatus, more posteriorly and inferiorly, known as the antitragus. And then finally, you have the ear lobe, which anatomists would call more technically the ear lobule. So that pinna, the most external part of the ear, makes up part of what anatomists actually call the outer ear or external ear. The outer ear or external ear includes that pinna on the outside of the head, as well as the whole external acoustic meatus, all the way into the point where it hits the tympanic membrane. So that's all what we call outer ear or external ear. The pinna and the whole external acoustic meatus right up to the right up to the tympanic membrane. Then if you look closely at this slide, you'll see there's a small cavity just inside the tympanic membrane or eardrum. The space that I'm circling with the cursor right now is what's known as the middle ear. This is, sometimes it's also referred to as the tympanic cavity because it lies just inside or just medial to the tympanic membrane or eardrum. But that tympanic cavity or middle ear cavity, that's the space where we find the three ear bones, the three ear ossicles. The first ossicle is called the malleus, which is the Latin word for hammer. And when you see it, despite the fact that it's going to be incredibly tiny, if you look closely at it, I think you can see where it gets that name. It has a long skinny handle and then a big rounded ball that looks like the head of a hammer. The handle of the malleus actually connects to the very center of the tympanic membrane, the very center of the eardrum. And then the head of the malleus sits off to one side within that middle ear cavity. The head of the malleus then articulates with the second middle ear bone or middle ear ossicle, known as the incus, which means anvil. So when someone first discovered these little ear ossicles, they noticed how the head of the hammer was in direct contact with this second bone. So they thought it was like a blacksmith, pounding on the anvil, like the hammer beating on the anvil. So that's the incus. The incus has two skinny projections that project out from it. One of those projections anchors the incus to the inside of the middle ear cavity. The other projection from the incus, if you look very closely at the slide, the other projection from the incus is connected to the third bone called the stapes. And stapes means stirrup, as in, the things you put your feet in when you're riding on a horse. And I don't know how well you can see it in the slide, but if you ever actually see one of these, if I ever find one again, or if you look closely at an enlarged picture of these bones in your anatomy atlas, you'll see it really, really looks like a stirrup. There's sort of a U-shaped part and then a flat part that's known as the foot plate, which would be what you would put your feet on, when you put them into the stirrups when riding a horse. This middle ear cavity, the space where the three ossicles are located, is connected to the pharynx by way of a tube that has several names. I call it just by the simple name on the slide here, auditory tube. Another term for it is pharyngotympanic tube, which is really more of a descriptive term because it refers to the fact that it's connecting the pharynx or throat to the tympanic membrane, or really to the tympanic cavity that lies inside the tympanic membrane. So pharyngotympanic is probably the most descriptive, most accurate term for it. A lot of you may have learned the name of this tube as eustachian tube, which I probably should have used a capital E here when I put the word eustachian because it's named after somebody. It's named after Bartolomeo Eustachi, who was an Italian anatomist during the Renaissance, who presumably was the one who first discovered this thing. But anatomists for many years now have been trying to get away from these eponyms, these things that are named after people, and replace them with more descriptive anatomic terms. So even though most people know the word eustachian tube, it's kind of falling out of favor among anatomists anyway. That eustachian tube or auditory tube or pharyngotympanic tube has an important role to help equalize pressure on the inner surface and outer surface of the tympanic membrane. So it's pretty obvious that air from outside the head can reach the outer surface of the tympanic membrane. If there's a change of pressure, a change in atmospheric pressure on the outside of your head, that's going to change the pressure that's pushing on the outside of the tympanic membrane. You need a way of equalizing that pressure on the inner side or surface of the tympanic membrane. So that's why this pharyngotympanic tube is there, to allow the pressure on the inner surface or medial surface of the tympanic membrane to equal the pressure on the outer surface. So you've all had the experience of going up a tall building in an elevator or something like that, and your ears will pop. What's happening as you go up in that elevator, there's lower atmospheric pressure the higher you go. And even if you're only going up a 10-story building, which is not particularly tall, there's enough of a change in atmospheric pressure that it reduces the pressure on the outside of your tympanic membrane. You may have air trapped inside the tympanic cavity, air trapped in that middle ear cavity, which is at higher pressure, as sort of sea level or ground level pressure. You have to allow some of that excess pressure on the inside to be released, so that the pressure on the inside equals the pressure on the outside of the tympanic membrane. So the sensation of the ears popping is when air is suddenly allowed to travel either in or out through that pharyngotympanic tube to cause kind of a sudden equalization of that pressure, and that's why you get that popping sensation. Some of you may have also had the experience of, flying in an airplane is another time when your ears will pop, because even though the cabin of the airliner is pressurized, it's never quite the same as it is down on the ground. So there is always a difference in pressure when you go up in an airplane. If you've ever flown with a cold, you may have had the sensation that you can't get your ears to pop. So you're going up to high elevation, the atmospheric pressure is lower. In spite of the fact that the cabin's pressurized, the air pressure is still lower. And so you've got low pressure on the outside of your tympanic membrane, higher pressure air that's still kind of trapped inside your head. And if you have a cold, then the mucous membranes lining this pharyngotympanic tube are all swollen. And so you can't get that rush of air going either in or out of that tube. And so if you've ever flown in an airplane with a cold, you may have had the experience of having pain in your ears, because that high pressure that's trapped in your head is now pushing outward on the tympanic membrane, stretching it, causing actual pain. You may have also had the sensation of not being able to hear anything when you're flying under those circumstances, because as you stretch that tympanic membrane, because of the difference in pressure on both sides, when you stretch it, it's less responsive to vibrations. And so you get this sensation. I've always thought it was like sticking your head in a toilet bowl or something. You just had this sensation that you couldn't hear anything. There was just sort of this hum that you'd hear all the time, but not, it's much harder to make out actual words. They always tell people when they're flying, if they have a situation like that, to swallow a lot, wiggle your jaw, or chew gum, which is just that mechanical motion of the mandible near the structures can kind of stretch out the walls of that pharyngotympanic tube and eventually cause the tube to open just enough to equalize that pressure on the inside of the tympanic membrane. Yeah.
When you swim or get water in your ears,
Yeah.
does it drain out of the
No.
So it doesn't go past the tympanic membrane?
Right. Under normal circumstances, the tympanic membrane should be completely solid. So water or air or anything on the outside cannot get into the middle ear cavity. That's why you have this problem with equalizing pressure, because you change pressure on the outside of the tympanic membrane. The only way to equalize the pressure on the inside is for air to go through your mouth and up the tympanic, up the pharyngotympanic tube to equalize pressure. There's no way for air to pass directly through, or water to pass directly through the tympanic membrane. Now, people can have ruptured tympanic membranes. I got to go off on a little tangent here, but we get back to this idea of ruptured tympanic membrane. When people have ear infections, a lot of people will mistakenly refer to them as inner ear infections. They are not inner ear infections. We'll talk about the inner ear in a minute. The inner ear is where the cochlea and the semicircular canals are. When you get an ear infection, it's a middle ear infection, more commonly known as otitis media. Well, not more commonly known, but among medical people, it's known as otitis media, which literally means inflammation of the ear. Media means middle. So it's an infection of the middle ear. So when you have a middle ear infection, it means that there's an infection that's probably spread from the pharynx up the pharyngotympanic tube into the middle ear cavity. And, as with any infection, at least if it's a bacterial infection, you can have pus that's formed. Pus can accumulate in there, or just mucus can accumulate in there, and it'll actually push outward on the tympanic membrane. And if it's untreated, it can actually rupture. People can have ruptured eardrums, ruptured tympanic membranes, just from an unchecked middle ear infection. So once the eardrum's ruptured, then sure, you can get water going into your middle ear cavity through your external ear, but under normal circumstances, you can't. Yeah.
Oh, is the, for kids that get like tubes
Yep.
in their ears, is that, they insert the tube through the tympanic membrane?
Right, that would be the only other situation where you would actually have an opening in your tympanic membrane. Is kids who get frequent middle ear infections, the surgeon will make a tiny little hole in the tympanic membrane. They'll put this little plastic ring in the hole that creates an actual opening. It's not enough damage to the tympanic membrane to affect their hearing. They're still going to have perfectly normal hearing.
Okay, because that was always my confusion. I was like, how can you put a hole in that membrane? You really shouldn't have a hole.
Right.
Why are they putting a hole?
Because they want any of that pus or other fluid that accumulates in the middle ear cavity to have a way to drain. So they're intentionally putting a little tiny hole in there, but they're putting this little plastic ring around it to prevent that hole from turning into a big tear that completely destroys the membrane.
Does that membrane heal itself?
Yeah. Yeah. My daughter's had these things put in like twice. And it's pretty common that they fall out. And then by the time you reach adulthood, usually kids who are prone to middle ear infections, they kind of grow out of that. And so then that little tiny hole will just heal itself just fine. Okay, so that's middle ear. It lies inside or medial to the tympanic membrane, and it's connected to the pharynx by way of the pharyngotympanic tube or auditory tube. The inner ear refers to these organs that are embedded within the petrous temporal bone. Actually, technically, the middle ear cavity is also embedded within the petrous part of the temporal bone. But all of these other structures are also embedded within the petrous temporal bone. And this includes the cochlea and the semicircular canals, or sometimes called the vestibular apparatus. So the cochlea is a spiral organ, looks like a snail shell, that's responsible for your sense of hearing. There are actually several different chambers running side by side that are all coiled together. I mean, you don't need to know this, but there's something called the scala vestibuli and scala tympani that are all coiled around. So it's not just one big tube like a snail shell that coils around. It's actually three separate channels side by side that are then all coiled into this big spiral. It's kind of hard to see on this picture, but the foot plate of the stapes, the part that you would put your foot on if you were actually, if this was a real stirrup and you were riding a horse, that flat foot plate of the stapes fits into a little window in the temporal bone known as the oval window. And the inside of that oval window is connected to these channels within the cochlea. So the way that you hear is that sound vibrations are kind of funneled through all of those little coils and spirals in your outer ear, that those sound vibrations are then transmitted through the external acoustic meatus to the tympanic membrane. And the vibrations then cause the tympanic membrane to vibrate sort of in and out, kind of like hitting the membrane on a drum. The vibrations of the tympanic membrane are then transmitted to the malleus, which then bangs on the incus like a hammer hitting an anvil. The incus then transmits it to the stapes, and the foot plate of the stapes then kind of vibrates in and out of that oval window. And it's like those wave machines at a water park. It creates waves of fluid that then propagate through these different fluid-filled channels in the cochlea. So there's fluid in here called endolymph, and waves of that fluid then kind of flow back and forth through the different spirals of the cochlea. And there are these little tiny hair cells that move in response to the movements of the fluid. And it's the stimulation of those little hair cells that give you your sense of hearing. The movement of the little hair cells is then translated into an electrical signal that then passes through the vestibulocochlear nerve to your brain. The vestibular apparatus consists of a couple of fluid-filled chambers. There's something called the utricle, something else called the saccule. But then most importantly, there are these three arches. They're called semicircular canals. It's literally a canal or a little channel that's embedded within the petrous part of the temporal bone. And there's three of them oriented in different planes. So there's a semicircular canal that's oriented roughly in the sagittal plane, so it's vertical and parallel more or less to your sagittal plane. There is a second canal that's oriented vertically but more in a coronal plane. And then there's a third set of canals that are laying horizontally, roughly in an axial plane. And as you move your head from one side to the other, forward and backward, as you change the position of your head and change your whole position of your body, fluid sloshes back and forth within these three canals. And there are hair cells within the canals, very similar to the hair cells within the cochlea. They respond to the movements of the fluid, and they give you a sense of the position and movements of your head. So it gives you your sense of position in space, your sense of equilibrium, your sense of balance. The vestibular also sends that information by way of the vestibulocochlear nerve. So you might recall vestibulocochlear nerve gets its name from the fact that it's innervating both the vestibular apparatus for your sense of balance and your cochlea for your sense of hearing. And of course, that vestibulocochlear nerve is passing through the internal acoustic meatus along with cranial nerve 7, along with the facial nerve. So when I do my demo dissection, what I'm going to attempt to do is grind off the roof of the petrous part of the temporal bone, expose right into the internal acoustic meatus and see if we can actually follow the nerve in there. And then the tricky part is trying to get down and around the cochlea without destroying it. And also I'm going to try to unroof the roof of the middle ear cavity to get down and expose the three ear ossicles as they actually sit within the middle ear cavity. I already mentioned that the bones are tiny. The cochlea and the semicircular canals are also tiny. A lot of these illustrations that you see kind of give a false impression about the size of these things. Probably every medical illustrator at some point in their career is going to reproduce this picture. Max Bradel, who was sort of the father of our modern medical illustration profession back in the early 1900s, did an illustration that looked very much like this one. And I don't know if everybody's just copying Bradel or if Bradel was copying somebody else that came before him. But this basic illustration has been copied over and over and over again and reproduced. with one enormous mistake. Now, Bradel was smart enough. I know he didn't do this by accident. He messed around with the scale and proportions, probably on purpose. And I think Netter probably knew better when he created this. He messed around with the scale on purpose. But what most people don't realize is that Netter messed around with the scale and Bradel messed around with the scale. So they just reproduce this and they assume that this is how big these things really are. I'll share the secret with you, and if you ever have to illustrate this, then you'll know how to illustrate it right, or you can make a conscious decision to use a little artistic license and mess around with the scale also, but at least you'll know that you're doing it. That external ear is tiny compared to what it really should be. The pinna out here should be at least twice as tall, if not bigger, relative to these structures in here. So the cochlea is not literally half the height of the pinna of your ear. The cochlea is smaller than my pinky fingernail. As a matter of fact, the cochlea, semicircular canals, and the entire middle ear cavity, that entire region is smaller than a penny. So, I mean, the way this is drawn, it makes the cochlea look like it's the size of a quarter. But you have to realize this whole area in here is smaller than an American penny. Yeah.
I noticed that the school here is like divided into different ones.
Right here?
Yeah.
Yeah.
Are those like two different bunches?
It's actually two different nerves. The vestibulocochlear is only the larger one down here. That's actually the facial nerve, cranial nerve 7, that just happens to run with it through the internal acoustic medium. All right. You're also going to, in lab, take a brief look at some of the anterior structures of the eye, really just identifying different parts of the eyeball that are visible from the front, as well as different parts of the lids. The lids themselves are referred to as the palpebrae. There's a superior palpebra and an inferior palpebra. And then the space between them, just the opening between the lids at the front of your eye, is known as the palpebral fissure. Bless you. And then the corners of the eye, where the upper and lower lids meet, are known as the canthus. There's a lateral canthus, which is simply the lateral corner of the eye where the two lids meet. And then there's a medial canthus at the medial corner of the eye where the upper and lower lids meet. The medial canthus, though, has an extra structure located there. That kind of pink area at the medial corner of your eye is known as the lacus lacrimalis. Kind of a fun Latin term, means the lake of tears, because this is where tears appear to emerge from the eye before they go streaming down your face. Some of the structures on the eyeball itself, I forgot to mention. The white part of the eye is known as the sclera. The iris is the colored part of the eye. And then the pupil is simply a hole in the middle of the iris. I mean, a lot of people assume it's a structure because it looks black. I mean, it looks black only because it's a hole, that's extending into the interior of the eye, but it's just an opening in the iris. That lacus lacrimalis, I mentioned it's called the lake of tears. I think a lot of people, before they learn any anatomy, they assume that tears are manufactured somewhere near the medial corner of the eye and they just come spilling out of that lacus lacrimalis. But what they don't realize is that the tears are actually produced in a completely different area. The tear fluid is produced by the lacrimal gland, which is located in the upper lateral corner of the orbit. So superior and lateral to the eyeball. So the tears are actually produced by this gland, which is nowhere near that lake of tears, that lacus lacrimalis at the medial corner. The tears are produced in that lacrimal gland in the upper lateral corner, and then they flow from the upper lateral corner of the orbit. They flow in a medial direction across the anterior surface of the eye, and they flow medially towards that lacus lacrimalis at the medial corner. And there's green arrows on this slide indicating that direction of flow from the lacrimal gland medially across the eye towards that lacus lacrimalis. The tear fluid that's produced by the lacrimal gland has a couple of functions. One function is just to keep the eye from drying out. The eye is a fairly sensitive structure, has some very delicate membranes on the surface of it, and if it's not kept moist all the time, it can be very bad, very damaging to your vision, and just plain irritating if your eyes get all dried out. But also that constant flow of fluid across the eye is constantly flushing foreign particles off of the surface of the eye. So it's flushing bacteria, viruses, dust, dirt, and other stuff off. So it's kind of like your own built-in cleaning system, to just constantly keep cleaning the front surface of the eye. So once that tear fluid flows across the surface of the eye, where does it go from there? Well, it reaches that area called the lacus lacrimalis. And most people have never seen this before. I suppose if you got out a magnifying glass and look closely at one of your lab partners, you notice that there are two tiny little holes located immediately above and below the lacus lacrimalis. These are called the punctae. And the punctae are entrances to a pair of tiny little canals called the canaliculi, lacrimal canaliculi. So when the tear fluid reaches that lacus lacrimalis at the medial corner of the eye, it's absorbed through the punctae into these little canaliculi. The canaliculi then flow into a sac called the lacrimal sac, which is located within a foramen in the lacrimal bone on the medial aspect of the orbit. If you look at one of the skulls, you'll notice there is actually a fairly prominent foramen. It's probably 3, 4, 5 millimeters in width in that lacrimal bone. So that's where the lacrimal sac sits. The lacrimal sac then leads into a duct known as a nasolacrimal duct, which then flows from the lacrimal bone down into the nasal cavity and drains into the nasal cavity just below the inferior nasal concha. So under normal circumstances, like right now, every one of us is producing a constant trickle of tear fluid produced by that lacrimal gland. It's flowing in a thin sheet medially across the surface of the eye. It's being gathered up at that lacus lacrimalis at the medial corner or medial canthus of the eye. It's being absorbed into those canaliculi, flowing into the lacrimal sac, from the lacrimal sac down the nasolacrimal duct and draining into our nasal cavities. It's happening to all of us right now. The only time that you actually cry is if you produce more lacrimal fluid than the little canals can absorb. And that's when they spill out onto your cheeks. And it looks like they're coming from the medial corner of the eye. It's just because there's more tear fluid accumulating there than you can absorb through the two little canaliculi. But you're always producing tears, just at a low enough rate that they can all be absorbed and they all flow down into your nasal cavity. We won't see most of what's on this slide, but everybody who studies anatomy should know the basic structure of the eye, because more than likely you'll have to illustrate it at some point in your career. I've heard that a picture like this shows up on the board certification exam from time to time. They want you to label some of the parts of the eye, so it's helpful to know the basic structure. So the eyeball is roughly a sphere, although not exactly a perfect sphere. You know, did you know that the Earth is not a perfect sphere either? The Earth is what's called an oblate spheroid, meaning it's a little fatter around the waist than it is tall, like some people I know. And it's because of the spinning of the Earth that makes it actually kind of stretches it out a little bit at the equator. I mean, it's not a lot, but it's enough that it's not a true perfect sphere. The eyeball is not a perfect sphere either, but it's called a prolate spheroid. It's actually a little taller than it is wide. So if you ever have to illustrate the eyeball, first thing you do is you draw a circle, and then maybe in Adobe Illustrator or something, just squish it a little bit from front to back. I don't know exactly how prolate it is. I don't know how, I mean, you don't want to squish it too much. You don't want to make like an actual ellipse, but it is squished a little bit from front to back. And then the anterior structures of the eye, the cornea, is almost like a separate sphere that kind of intersects with the bigger sphere that makes up the more posterior part of the eyeball. So when I've illustrated this before, I mean, I illustrated this here, by the way. But when I've illustrated this before, you know, that's how I've done it. I've drawn a circle, squished it a little bit front to back, drawn a smaller circle to represent the cornea, and then you can use one of your Pathfinder tools or something in Illustrator, merge them together into one shape. So it's almost as if the cornea is a separate sphere that's kind of attached to the front of the larger sphere. The larger sphere, the posterior part of the eyeball, is made up of three primary layers. The outer layer is the sclera. This is the white part of the eye. It's fairly tough. Its primary job is just to allow the eye to maintain its shape and to provide some mechanical protection to the eye. Then just deep to the sclera, the layer shown here in pink, is the choroid. This is the primary vascular layer of the eye. It's where you find the blood vessels of the eye. And then just deep to the sclera, just deep to the choroid is the retina, shown here in yellow, which of course is the photoreceptive layer, the light receptive layer. And the cells of the retina are basically all nerve cells. Those cells then join together to form the optic nerve, which of course is what gives you your sense of vision. One thing I'll tell you about this picture is also not entirely to scale, but I did that on purpose because I knew better. The choroid and the retina are much too thick in that little cutaway in the upper left. The sclera is the only layer with any significant thickness to it. The choroid is almost microscopically thin. The retina is definitely microscopically thin. So in this picture, you wouldn't even see them if I didn't kind of exaggerate them a little bit, give them a little thickness. The sclera, or white part of the eye, as it comes around to the front, it actually transitions, and it's a little hard to tell, but if you look closely where I'm circling with the cursor, you may be able to tell that sclera, or white of the eye, actually transitions to become the cornea, which I've always found a little surprising, that the sclera, the opaque part of your eye, is actually the same layer as the cornea, which is the clear part in the front of the eye. They actually have some similarities in structure, but the cells are organized in such a way that the cornea part is optically clear. It's completely clear, like a piece of glass. The choroid also extends all the way around to the front, and the choroid enlarges somewhat when it gets close to the front of the eye to form something called the ciliary body, which is actually labeled down here at the bottom of the slide. So the choroid is expanding to form the ciliary body. And there are two different parts that are identified here. The more posterior or outer part of the ciliary body is known as the pars plana, which just means the flat part. And then there's a kind of an enlarged part known as the pars plicata, which means the folded part, or plicated part. And the ciliary body does a couple of things. It produces fluid. There's fluid that's constantly circulating inside the eyeball, called aqueous fluid, not to be confused with the tear fluid that we talked about a minute ago. The tear fluid is on the outside of the eye, just flowing over the surface of the eye. But there's actually fluid produced inside the eye, which is also constantly circulating through the eye. We'll talk about that more in a minute. That fluid is being produced by the ciliary body. The ciliary body also contains the ciliary muscle, which we've talked about before, and actually it was on the exam. The ciliary muscle is the muscle that actually changes the shape of the lens for close-up vision, or what's called accommodation. So there are these fibers that are kind of like tendons. I'm not sure that they have the same structure as a tendon, but these little fibers called zonule or zonular fibers that connect the ciliary body to the lens. And the movements of the ciliary muscle then basically pull on the zonule, and that's what changes the shape of the lens. The choroid and the ciliary body are also continuous with the iris, which is the colored part of the eye. And that's basically just a fairly thin flap that extends anterior to the lens and completely surrounds the front of the lens. And then the pupil is just a hole. It's just the space in the center of the iris. The iris contains two muscles as well. The sphincter pupillae muscle, which is the muscle that's under parasympathetic control, which constricts the pupil to allow less light into the eye. And then there's also a muscle called the dilator pupillae, which pulls the pupil open, dilates the pupil to allow more light in. And dilator pupillae is under sympathetic nervous system control, which we'll talk about next week. The iris also separates two chambers of the eye, which are important for the circulation of fluid through the eye, which again, we'll talk about in a minute. There's a small area that sits just posterior to the iris, kind of between the iris and the lens. That's known as the posterior chamber. And then the anterior chamber is the area that lies anterior to the iris and anterior to the pupil. And it's covered by the cornea. So let's take a look. Oh, and I'll just point out there's something called Schlemm's canal that sits right at the intersection between the cornea and the sclera, and I'll tell you why that's important in just a second. That's one that's named after somebody that nobody apparently has come up with a better name for it yet. So everybody still calls it Schlemm's canal. Yeah. And when you go to the eye doctor, they are putting, I think what they're putting in your eye exactly. They are stimulating the dilator pupillae muscle. So they're not paralyzing the sphincter, they're stimulating the dilator muscle. So my guess is it's probably either epinephrine or something comparable to epinephrine, which is going to stimulate the sympathetic nerve endings that innervate that muscle. What's that?
It's orange.
Yeah, it's kind of yellowy orange, yeah, in color. But I'm not 100% sure what's actually in it chemically, but I do know it's just stimulating the dilator pupillae muscle. So here's a close-up of these chambers of the eye. Just as a reminder, the posterior chamber is this area back here that sits posterior to the iris, roughly between the iris and the lens. And then the anterior chamber is the much larger space that lies anterior to the iris and includes the whole space basically covered by the cornea. And I mentioned that the ciliary body, one of its jobs, in addition to containing the ciliary muscle, one of its jobs is to produce fluid. It's known as aqueous fluid, or an older term sometimes you hear is aqueous humor. That fluid's produced in the ciliary body, and it flows between the iris and the lens. You notice there's a fairly narrow space here between the iris and the lens. That fluid flows from the posterior chamber between the iris and lens and then into the anterior chamber. And then it circulates within the anterior chamber and eventually makes its way over to this canal located over at the junction between the sclera and the cornea, this Schlem's canal or canal of Schlem. And the fluid is reabsorbed into that canal and then ultimately reabsorbed back into the venous bloodstream. So your eye is constantly producing this fluid internally, this aqueous fluid internally from the ciliary body, and it's constantly being reabsorbed through the canal of Schlem and then being returned back into the bloodstream. Glaucoma results from something that messes with this. There's a couple different causes of glaucoma. You can simply overproduce aqueous fluid so that the fluid starts to build up in the chambers of the eye. That increases the pressure in the eye. Another way to get glaucoma, there's something called closed angle glaucoma, where something blocks the entrance to Schlem's canal. What can happen is that the iris actually gets too close to the cornea, and it kind of prevents the fluid from getting back up into that little tight space where the canal is. And by blocking the outflow of fluid, even if you're producing a normal amount of fluid, if you're preventing it from getting out of the eye, it's going to accumulate in the eye, it's going to increase the pressure. So glaucoma is simply an increase in pressure inside the eye, but it's a bad thing because it damages your optic nerve.
If they were to like remove the whatever was obstructing it, would they be able to get rid of the glaucoma, or would it be like kind of like it is what it is then?
No, you can, there's various treatments depending on what's causing it. So there are ways of opening up the angle. There's one thing that closes the angle is there's something called a neovascular membrane that forms on the front of the iris. I think they can laser that out. If it's not closed angle glaucoma though, if you're simply producing too much fluid, then they just give you eye drops that you take for the rest of your life. And it just reduces the production of aqueous fluid. AJ, do you have?
It was a stupid question.
It was what?
It was a stupid question.
Stupid question. Okay. All right, so you won't, as I said, you won't see any of that internal stuff in the eye, even if somebody decides they really want to remove an eyeball and cut it in half. I'm afraid it's just not very gratifying. It's the eyeball looks gray, you cut it in half, the inside's just black. The only cool thing in the eyeball is the lens. The lens will come out and you get to see the lens.
But actually, ask myself.
Okay.
The floaters you see in your eye, is it from the tears being produced, or is it
The floaters are inside.
They are. Oh my God.
Yeah, and they are mostly, actually not even in the anterior posterior chamber, they're in the way back chamber, which I didn't mention this, but
That's why it's magnet.
that whole big yellow space in the back of the eye behind the lens is filled with jelly. It's not really jelly. It's called vitreous humor. So the watery fluid that circulates around in your eye in the front is aqueous humor. The stuff in the back of the eye is called vitreous humor. It's made out of long protein chains. Protein or hyaluronic acid. I don't know. I'll have to double check on it. But it's made out of long chain of something, long polymers. And the floaters that people get are back there. They're back in the vitreous.
Are they actually particles, or-
It's yeah, there's little particles, there's just stuff that accumulates in the vitreous in that sort of meshwork of it's you know, I once had an eye doctor describe it to me as being like a great big bowl of spaghetti, because as I say, the vitreous is these long chain molecules, these long polymers. So it's just like a tangle of strands of spaghetti. So I think they're probably just like impurities and stuff that are kind of trapped in that tangle of either protein or one of the extracellular matrix molecules. I can't remember exactly what it is now. All right, so your actual dissection today is going to be this superior approach to the orbit. So as I was saying earlier, you're going to look in the anterior cranial fossa. You're going to take a hammer and probably one of the smaller chisels, and you're going to give a few gentle taps to the frontal bone, which forms the roof of the orbit. It's a little thicker than an eggshell, but not much. So be pretty gentle. Then you can use one of the small pairs of bone pliers or something to just pick out those little fragments of bone. And you'll expose a membrane first, which isn't shown in the slide, but there's a membrane that covers the roof of the orbit called the periorbita. It's really just the periosteum, the membrane that surrounds the bone. It just happens to be the periosteum that sits on the roof of the orbit. So you'll have to incise through that periosteum or periorbita. And the first thing you'll come to actually is a nerve, which I'll show you on one of the upcoming slides. There's a big nerve that sits right on the very top of the orbit called the frontal nerve. So you're going to want to try to preserve that nerve. But then you'll just be removing bits of fat from the orbit. This whole space that you see here is all filled in with fat. And so you'll be just picking out little bits of fat with some forceps to try to expose these different muscles as well as some of the other nerves in here. So the first two muscles you're going to encounter at first might actually look like one muscle because they're sitting right on top of one another, and they often look kind of like they're fused together, but they're really not. The most superior muscle, the one that you literally encounter first when you get into the orbit, is that levator palpebrae superioris. The muscle is originating from this tendinous ring at the back of the orbit. In fact, almost all of the muscles in the orbit are originating from that tendinous ring back here. This tendinous ring is actually surrounding the optic nerve just before the optic nerve goes through the optic canal. So levator palpebrae superioris is originating from that tendinous ring, and it's inserting into what's called the superior tarsal plate, which is just the upper eyelid, basically. And this is the primary muscle responsible for opening your upper eyelid. And then immediately inferior to that, and often, like I say, kind of sandwiched together, they almost look like they're fused, is the superior rectus muscle. That also originates from that tendon in the back of the orbit and inserts on the top of the eyeball. And when this muscle contracts, it pulls the top of the eyeball back, which rotates the front of the eye up to allow you to look up. Notice that I've included the innervation of these muscles in parentheses, so they're both innervated by oculomotor nerve, cranial nerve 3. Then you'll remove some more fat over towards the medial aspect of the orbit. You may have to use the little bone pliers to nibble away a little bit of the ethmoid bone to expose some of these medial muscles. The first of these that you should encounter is the superior oblique, which also originates from that tendinous ring. The muscle then travels forward, passes through that little cartilage loop called the trochlea, and then that allows the tendon to redirect, and it inserts on the top of the eyeball. And this one muscle, just superior oblique acting all by itself, can actually allow you to look down and laterally simultaneously because of the way it's pulling at this strange angle on the top of the eyeball. But it also has the effect of helping to rotate the eyes. So the eyes will rotate back and forth as your head turns in order to maintain a horizontal view of the horizon. Remember that superior oblique is innervated by cranial nerve 4, the trochlear nerve. A little deeper, just inferior to superior oblique, is going to be medial rectus, which is another one innervated by cranial nerve 3. Then you'll turn your attention to the lateral part of the orbit and pick out some more fat over here to expose the lateral rectus, which is, again, originating on that tendinous ring, inserting on the lateral part of the eyeball, and would pull the lateral part of the eyeball posteriorly, which causes you to look away from your nose which is abduction. And that's innervated by cranial nerve 6, the abducens nerve. A couple muscles you probably won't see. You probably won't be able to get deep enough into the orbit to see inferior rectus. Just know that it's down there. And you definitely will not see inferior oblique. Inferior oblique is the only muscle in the orbit that doesn't originate from that tendinous ring at the back of the eyeball. The inferior oblique is actually originating from the maxilla near the medial corner of the orbit, and it simply goes, the muscle just goes sideways, attaching to the inferior aspect of the eyeball, but we won't see that one at all for sure. So while you're looking for these muscles and trying to identify them, you're also going to be trying to look for some of the nerves in the orbit. I mentioned that the biggest nerve here in the orbit, well, besides the optic nerve itself, but the first nerve you're going to encounter immediately after you remove that membrane is this frontal nerve. Frontal nerve is part of V1. In fact, all the nerves labeled here in the upper right are all branches of V1, the ophthalmic division of trigeminal. The frontal nerve is the largest of these branches of V1, and then it splits to give rise to two of the others. So the frontal nerve is going to split into the supraorbital nerve, which is going to come out the supraorbital foramen just above the orbit. And then there's a smaller supratrochlear nerve that exits very close to that trochlea near the medial corner of the eye and passes up onto the forehead. Both of these are sensory nerves to the skin of the forehead, but they're passing through the orbit before going up onto the forehead. There's also a lacrimal nerve, which is a branch of V1. The lacrimal nerve, which is coming off of V1, is actually just a sensory nerve. It is not innervating the lacrimal gland. I mean, it's innervating the lacrimal gland in the sense that it's a sensory nerve to the lacrimal gland, but this is not the nerve that's responsible for stimulating the lacrimal gland to produce tears. If you remember to the previous exam, I know it's been a while, but the production of tears is actually controlled by parasympathetic neurons within cranial nerve 7, facial nerve. So this is just a sensory nerve to the lacrimal gland, but not the nerve that innervates it to produce tears. Some of the other nerves you might find in here, trochlear nerve. This one's kind of tricky to find. It's very tiny. Basically, if you find the superior oblique muscle and you see a tiny little nerve twig entering into the superior oblique, then you've found your trochlear nerve. Same thing with the abducens, cranial nerve 6. You probably won't actually see it going through the superior orbital fissure, but if you look at that lateral rectus muscle, first you want to identify lacrimal nerve, but if you see another little nerve branch that's going into the belly of the lateral rectus muscle, and that would probably be abducens. You'll see a little bit of cranial nerve 3 in here as well. You are going to do a little bit deeper dissection. You will have to cut the levator palpebrae superioris and the superior rectus muscles. I can't remember where the dissector tells you to cut them. Just do whatever the dissector tells you to do. But you get those two muscles out of the way that allow you to get a little bit deeper in here. Here now you can see that abducens nerve going into the lateral rectus to innervate it. And you can see some of the branches of cranial nerve 3 in here as well, oculomotor nerve. And one final branch of V1 that wasn't visible on the previous slide. There's a nerve that comes over towards the medial wall of the orbit called the nasociliary nerve. And that has branches that extend out onto the bridge of the nose to be sensory to the skin on the bridge of the nose. It also has sensory branches that go into the ethmoid bone to innervate some of the nasal mucosa inside the nasal cavity. So that is what you're doing today.